Hello, everybody. Good afternoon to you all. So we'll be starting a new topic. That's periodontal flap. Okay. So in the previous class, I think we have covered on the gingival surgeries, isn't it? Under which we covered two surgical protocols. That is gingival curettage and gingivectomy. Okay. So today we'll start with a new topic. So I'll be covering this topic under these headings. Okay, first we'll be talking about the critical probing depth, definition of periodontal flap, a little bit on the history, the rationale, indications, contraindications, classification of periodontal flaps, incisions used in periodontal surgery as such, and then we'll go about with each individual surgical procedures like original Widman flap, modified Widman flap, bically reposition flap, papilla preservation flap. Then we'll be talking on the healing of flap, outcomes of flap operation, a little bit on the complications and the failures related to periodontal flap surgical procedures. Okay. So when we talk of treatment related to periodontal diseases, there are two different treatment protocols. One is a non-surgical treatment aspect, and then another one is your surgical periodontal aspect. So that's non-surgical periodontal treatment, otherwise called as NSPT, right? As you know, consists of supra and subgingival plaque, professional mechanical plaque removal. This is a recent terminology, right? So earlier we used to call it as supra and subgingival scaling and root planing. So the newer term given to that supra and subgingival scaling is nowadays referred to as supra and subgingival professional mechanical plaque removal, right? So which involves the supragingival debridement as well as subgingival debridement, and then you also do a procedure called root planing, right? Now, along with that, you can also use antibiotics as an adjunct. Okay, so you can use it systemically or you can use it locally, right? So again, the European Federation of Periodontology, or the EPF, has given in a recent treatment guidelines for periodontology, has again not recommended the use of adjunctive use of antibiotics. They say there is absolutely no rationale behind using this antibiotics as an adjunct. But then they left it to the practitioners, saying that if at all you go by case, if that case warrants an adjunctive use of antibiotics, then you can always place the patient on adjunctive use. It's adjunctive use, right? Not as a solo treatment. So along with this supra and subgingival PMPR, you can also advocate the patient's proper use of oral hygiene practices. Okay, that includes brushing, flossing, use of interdental brushes, maybe sometimes adjunctive use of chemical plaque control method, right? So along with that, lasers also have been used as an adjunctive to this non-surgical periodontal therapy, right? This is one of the adjunctive use. So though it is considered as a gold standard, okay, as a treatment protocol, but still there is a roughly about 0.05 to 0.3 mm attachment loss in patients who have periodontitis and have not undergone a surgical protocol. So there is still a venue or a good scope for patients undergoing this surgical periodontal therapy, right? Now, all this, whether it is a non-surgical periodontal therapy or whether it is a surgical periodontal therapy, depends on this critical probing depth. So what is this critical probing depth? Now this is a threshold probing depth. Okay, now this definition basically, or this concept, was put forth by Jan Linde in the year 1982. He defined this as a threshold probing depth where there is expected gain in the clinical attachment after you do any treatment, right? So let's see this sentence. Critical probing depth for SRP, that is subgingival scaling and root planing, was, according to his study, is 2.9 mm, right? That means if you do a subgingival scaling and root planing for a pocket depth more than 2.9 mm, you have an attachment gain. Are you getting right? So if you do a scaling and root planing for a pocket depth which is less than 2.9 mm, that means you're going to induce attachment loss. Good, right? Okay. So the critical probing depth for the flap surgery is supposed to be 4.2 mm. Okay, right? And then that means if you do a periodontal surgery for a patient who is having a pocket depth less than 4.2 mm, that means you're going to induce attachment loss. If the pocket depth is more than 4.2 mm, that means you're going to have a attachment gain. Okay. Now, as the pocket depth increases, okay, your non-surgical periodontal therapy becomes ineffective. That means your subgingival scaling instruments, right, will not be able to go deeper to the pocket depth. That is what I mean to say. That means if let's assume there is a pocket depth of 6 mm or 5 mm, your instruments will not be reaching to that level. And since this subgingival scaling and root planing is supposed to be a blind procedure, you are not sure basically of whether you're going to completely remove the local factors or not. So that is one of the major criteria. So that is what this sentence means. As the pocket depth increases, that is more than 3.73 mm, right? This subgingival scaling and root planing most of the time is supposed to be ineffective. As a pocket deepens, if you do a periodontal flap surgery, studies again have shown there is a gain in the attachment, right? So several techniques have been used for the treatment of this periodontal pockets, and periodontal flap is one of the frequently employed procedure to treat periodontal pockets. So why this periodontal flap is so important? Number one, it not only provides access to the underlying tissues. When I say underlying tissues, it means to the root surface as well as to the bone surface. Okay, number one, it provides accessibility and visibility to the root and bone surface. Also, what it does is, if at all there is any defects related to the bone, especially if there is a favorable bony defects like your 3-wall defect or a 2-wall defect, right? Then you can also perform a variety of regenerative procedures. You can put in bone grafts, you can put in GTR membrane, etc. Why? To get the best results out of your surgical procedure, right? So let's go into the definition of this periodontal flap. So there are two definitions here, right? One is according to Carranza and one is according to the glossary of periodontal terminologies, right? So according to Carranza, what Carranza says is that a periodontal flap is a section of the gingiva or of the mucosa which is surgically elevated, right, from the underlying tissues to provide visibility and accessibility to the bone and root surface, right? So it is a section of the gingiva and or of the mucosa surgically elevated from the underlying tissues to provide visibility and accessibility to the bone and root surface. This is according to Carranza. Now, according to the glossary of periodontology terms, okay, a flap is defined as a separation of a section of a tissue from the surrounding tissues except at the base. So the base is intact. You are just going to reflect the tissue from the coronal aspect. Okay. So let's see a little bit of history of this periodontal flaps. Okay. So it is not that prior to 1918 there were no evolution of flaps. There were much, but then the first recorded literature starts from Leonard Widman, who devised or proposed this surgical technique called as the original Widman flap. So in 1920, Newman proposed another surgical procedure, flap surgery, that is called as a mucoperiosteal Newman flap. Modified flap operation was proposed by Kirkland in the year 1931. Neighbors in 1954 gave another surgical procedure called as repositioning of the attached gingiva. It was basically modified by Friedman in 1962, who called it as apically repositioned flap. Morris in 1961 gave unrepositioned flap, and way back in 1974, it was Ramford and Nizel who modified the original Whitman flap, and they called it as a modified Whitman flap. So in 1985, Takai gave a much newer and minimal invasive surgical protocol called as the papilla preservation flap. And then after that, also there were a lot of flaps which were suggested. So let us see what is the rationale of periodontal flap surgical procedures. Okay? So the first and foremost thing is to enable visualization of the root surface for complete root debridement. That is the first rationale. Okay. The second one is whenever the attachment apparatus has been lost due to periodontal diseases, it is one of the objective that when we do a periodontal surgical procedure, we do also additive osseous surgery along with that. Third one is to re-establish the healthy clinical status of the periodontium with long-term stability. That means whatever the surgical procedure we do, it also make sure that the results obtained from the surgical procedure is maintained for a longer period of time. So let us see what are the indications of flap surgery. So the first one, as I said earlier, it is to gain access for thorough and complete root debridement. That is the first indication. So whenever you want to reduce or eliminate pocket depth, okay, so that the patient can maintain root surface free of this plaque biofilm. The third one is reshaping of the soft and hard tissues to attain a normal contour, or what we call a topography. And whenever there is a destruction of the attachment apparatus, right, if there are bony defects which are favorable for regeneration, then the periodontal surgical or flap surgery is indicated. And then facilitation of proper restorative therapy. So whenever there is a restoration has to take place, for example, a crown has lost much of its, a tooth has lost much of its crown portion. So we need additional exposure of the crown structures for a proper restorations to take place. So here, most of the time, we can use a apically displaced flap again, right? That's one of the indications for your periodontal flap surgery. Again, let's see what are the contraindications for the periodontal flap surgery procedures. Any medical condition, that means any uncontrolled medical conditions, is not an indication for periodontal flap surgical procedures. May it be unstable angina, uncontrolled hypertension, and uncontrolled diabetes mellitus. If these conditions are under control, then they become a regular candidate for your periodontal flap surgery. But if these systemic conditions are not under control, right, they are not the candidates. Myocardial infarction or stroke within 6 months, because there is always a chance for this episode to occur again. So we don't want to stress this, put the patient under stress of this periodontal surgical procedure. So it is always better that you postpone if required for after 6 months. Poor plaque control plays a very important role. Plaque control, as you know, it plays a very important role, right? So you might do a good surgical procedure, but if the patient compliance after your surgical procedure is not good, then you will end up in a disaster, or maybe you end up in a recurrence of the periodontal diseases. So it is either you motivate the patient to maintain his oral hygiene, right, and then you follow up with the surgery. But still, even after repeated motivation and instructions, if the patient is not able to maintain his or oral hygiene, then they are not the candidates for your periodontal flap surgical procedures. Last one is unrealistic patient expectation, right? So there may be a complete destruction of the bone, and the patient wants regeneration of the bone, and particularly if there is a one-wall defect, right, or if there is a complete destruction, horizontal bone loss extending up to the apical third, and if the patient requires a complete regeneration, then that is not that's not possible, and they are not the good patients as well as for your periodontal flap surgeries. Now let's come to the classification of periodontal flaps. Okay, so periodontal flaps are classified they are classified into three types. Excuse me. Yes. So periodontal flaps are basically classified into three categories. The first one is based on the bone exposure after flap reflection, right? So whether you're going to expose the bone or not, right? That's the first classification after you reflect the flap. So these are two types. One is a full thickness flap, and then one is a partial thickness flap. So based on the bone exposure after the flap reflection, it could be a full thickness flap or it could be a split thickness flap or a partial thickness flap. Based on the flap placement after you do the surgery, that means after you have performed the surgery, whether you want to put back the flap at the same position, right, that are called as non-displaced flap, or you want to displace this flap either apically or coronally or laterally. Those are called as displaced flap. Are you getting this? Yes, right. So that means you have reflected a flap. Now you want to put back the flap after you finish the surgery. Now it depends on what objective you are. What is the objective of that surgical procedure? If there is a recession, definitely you would want to do a coverage. So you do a coronally advanced one, or a laterally displaced flap, right? I will be teaching. I'll be discussing this a little bit later at the appropriate slide. Okay. So based on the flap placement after surgery, it could be a non-displaced flap or it could be a displaced flap. The last one is how well do you manage the papilla, right? Based on the management of papilla, periodontal flaps can be classified as a conventional flap or it could be a papilla preservation flap. Okay, so three types based on the bone exposure after flap reflection. It could be a full thickness or a partial thickness. Based on the flap placement after surgical procedure, it could be a non-displaced flaps or it could be a displaced flap. Based on the management of the papilla, it could be a conventional flap or it could be a papilla preservation flap. Okay, right. So let's go into each one. Okay, the first one is, as I said, depending on the exposure of bone after you reflect the flap. Two types. I said one is a full thickness flap and one is a partial thickness flap. So let us see the first one, that is a full thickness flap. Full thickness flap is also called as a mucoperiosteal flap. Okay, a mucoperiosteal flap. Okay, so it consists of reflection of a complete flap. That means it includes the flap includes the epithelium, it includes the connective tissue as well as the periosteum, right? So the periosteum is the outer covering of your bone. So you're going to expose the bone. Okay, in other words, you're going to means that you're going to expose the bone. So right, this flap, that is why it is called as a full thickness, right? So it consists of epithelium, it consists of the connective tissue as well as the periosteum, right? So basically, once you give the incisions, right? Once you give incisions, you're going to reflect this flap by using various periosteal elevators. Okay. So what is the objective? The objective is it gives accessibility to the bone surface, either for contouring if the bone is irregular, or if there is a bony defect which is favorable for regenerative procedures, you can go ahead with placement of grafts along with the GTR, right? So this is your full thickness flap, also called as a mucoperiosteal flap, right? So when you see this diagram, right, when you see this clinical picture, right, when you see here, this picture exactly shows you a 3-wall defect. Okay, 3-wall defect means 3 walls are intact and 1 wall is missing, right? Now this is one of the most favorable type of bony defects for regenerative procedures, right? So there is a nice contained defect where you can nicely remove all the granulation tissue and do a nice thorough root debridement and fill this area with bone grafts. Okay. Now here also basically there is a deep intrabony defect. Intrabony defect means when the base of the pocket is much apical to your surrounding alveolar bone, okay, or the crest of the alveolar bone, right? So here when I say full thickness, that means bone is exposed, right? So you have a flap which is reflected, right? So that it helps you to find out the morphology of your bony defects as well. Okay, right? So let's go to the second type, that is your partial thickness flap. So partial thickness flap is also called as a split thickness flap, or it is also called as a mucosal flap. Okay. Now, as I said, full thickness flap, you are going to incise, you are going to place the incisions with your scalpels, but you're going to reflect it with your periosteal elevator. But here, you're not going to elevate this split thickness with a periosteal elevator. This requires a sharp dissection. Okay, right? Because we don't want the periosteum to be lifted out. If you are going to lift out the periosteum, that means you're going to do a full thickness flap rather than a split thickness flap. Okay, so here this flap basically consists of only of the epithelium and a small thin layer of your connective tissue, and the periosteum is still intact on the root surface or on the bone surface. Right? So these indications basically for this partial thickness flap is these are used in mucogingival surgical procedures. Okay, so I'll show you this clinical picture, and you see here, right? So we are given a vertical releasing incisions. We have raised a partial thickness flap wherein there is a periosteum still intact, right? So here this flap basically only consists of epithelium and a small or a thin layer of connective tissue. So periosteum is intact, and these are basically used in mucogingival surgical procedure like this, where we are now trying to coronally advance this flap to cover this root recession. Okay, right. So the second one is basically, as I said, depending on the placement of the flap after you do the surgical procedure. So there are two types. One is a non-displaced flap, or it is also called as a undisplaced flap, wherein you're going to give incision, you're going to raise a flap, you're going to do a root debridement, and then after you finish your surgical procedure, you're going to put back the flap at the same place, at the same position where it was prior to your surgical procedure. This is called as a non-displaced flap or a displaced flap. That means you have given incision, you have reflected, and once you finish your surgery, you are going to put it back at the same position, right? That means you raise it here, you're going to put back at the same position. You're not going to displace it from its original position. That is called as a non-displaced flap or a undisplaced flap. Okay. The second category of this type is a displaced flap, just the opposite. That means you're going to give incision, you're going to raise the flap, you're going to do a root debridement. Now you can position this flap wherever you want to, depending on what objective you want to derive out of your surgical procedure. That means you can put this flap apically, then it is called as an apically repositioned flap. If you're going to place this flap coronally, then it is called as coronally advanced flap. And if you're going to put it laterally, this is called as a laterally displaced flap. Okay. Now, when you see this clinical picture, right? Now, this flap basically, which was here, was placed at a much apical position. So this becomes your apically displaced flap. Okay, that means original position here, but when we are putting it back, we are putting it at a much apical position. This is called an apically displaced flap. The second one is basically coronally. Now here, this is called, we are giving a semilunar incision here. There was earlier recession here. So what we do is give a semilunar incision here and then push this flap coronally and then suture it. That means the flap position was here. Now we advanced it coronally and then we have sutured it. Now this is called as a coronally advanced flap. Now here again there was a recession of your root surface, and then we have given a split thickness flap. We have raised, we have migrate, and we have just pushed this laterally and then sutured it. Right. So original position was here. We have pushed it here and then covered this root recession. Now this is called as a laterally displaced flap. Right. So displaced flap meaning that you have displaced that flap from its original position to a new position. It could be apical, it could be coronal, or it could be lateral. Understand? Okay. So the next one is based on how you're going to manage the papilla. So the two types, one is a conventional method, and then one is a papilla preservation flap. So in a conventional flap, what you're going to do is you're going to give an incision such that it is going to split the papilla into a buccal papilla and a lingual papilla, right? So here, when you see this clinical picture, we are given a clavicular incision, okay, and then we are reflected a buccal flap, as well as there would be a lingual flap on the palatal aspect. Now, this is called as a conventional flap. The second one is your papilla preservation flap. Here, what happens basically is you're going to give incisions at the line angles or at the crevice, right? And then from the palatal surface, you're going to give a semilunar incision and push the entire papilla onto one side of your flap. That means you're not going to split the papilla into two. Rather, you're going to push the papilla into one to be accommodated into one of the flap. Later, you're going to do a root debridement. If at all required, there is a vertical defect, you're going to go in with your bone grafts and then push back this papilla and then suture it, right? So we are not going to split the papilla. Papilla is going to be incorporated into one of the flap. Let it be a buccal flap, or let it be a lingual or a palatal flap. So this is called as a papilla preservation flap. Okay, right? So three types of classification. One is based on the bone exposure as full thickness and partial thickness. Based on the placement of flap after surgical procedure, it could be undisplaced flap and then displaced flap. The last one is how you manage the papilla. There are two types. One is your conventional flap, where you're going to split the papilla into buccal and lingual, and then the second one is your papilla preservation flap, where we are going to incorporate the entire papilla into one of the flap. Let it be a buccal flap or your palatal flap, right? Okay. Let's go into the little bit of fundamental principles of flap surgery. Okay, so under this, we'll be dealing with the incisions, how we are going to manage the papilla, the flap elevation, the flap co-adaptation and closure, and then the healing of the flap surgery. So let us see what are the incisions which are used in periodontal surgery. So here, incisions basically can be broadly classified into horizontal incisions and vertical incisions. Okay. So when I say horizontal incisions, it means these are the incisions which are directed along the gingiva in a mesiodistal direction. Okay, that means you're going to give these incisions along the horizontal direction in a mesiodistal direction. Okay. Now, once you give an incision and once you reflect a flap or elevate a flap, it provides sufficient access to the root surface as well as to the bone surface. These type of flaps are called as envelope flap. Okay, you've seen an envelope, right? Envelope basically it's lifted out like this, isn't it? So it is going to be lifted out like this. That means the base is intact, but still you have sufficient access to know what is there inside the envelope, right? So that is what is meant by an envelope flap, right? So again, I repeat, horizontal incisions are given along the mesiodistal direction, and it provides sufficient exposure or access to the root surface and to the bone surface, and these are called as envelope flaps. Vertical incisions are basically can be given at either end of this horizontal incision. That means you are given a horizontal incision, right, in the mesiodistal direction, and then you are going to give two vertical incisions like perpendicular to this horizontal incisions. So these are called as vertical incisions, okay, or it is also called as releasing incisions. Okay, if you remember the diagram which I had showed you, right? Just go back to that just to make sure and make you understand what do you mean by yes. Now when you see here, right, now this is perpendicular to this horizontal incisions. If you see the incisions, if we are going to place it mesiodistally, these are called horizontal incisions, and if the incisions is perpendicular to this horizontal incisions, these are called as vertical incisions. Okay, right? So are we clear about it? So these are vertical incisions, right? And these are at the end of this horizontal incisions, right? The horizontal incisions are extended from here to the here. So at the end, basically, we are going to give vertical incisions. So these are called as releasing incisions. Okay, right? Okay, so we go back to the yes. So these are called as releasing incisions. Okay, so let us see what are the horizontal incisions. Okay, the first horizontal incisions most of the time given in a periodontal flap surgery is called as an internal bevel incision, or it is also called as the first incision. Okay, first incision, right? In a flap surgery, most of the time when we use a modified Widman or a original Widman flap, the first incision is called an internal bevel incision. It is also called as a reverse bevel incision. Okay, right? So don't get, or a inverse bevel incision. So three terminologies. One is an internal bevel incision, one is called an inverse bevel incision, and one is called a reverse bevel incision. All are same. Okay, internal bevel, inverse bevel, reverse bevel. Okay, right? So remember these terminologies, right? Incision, internal bevel, inverse bevel, reverse bevel, all the same. Okay, this is the first incision used in flap surgery, especially in modified Widman and in original Widman flap, right? So that's why I said this is also called as a reverse bevel or inverse bevel. So what is the objectives behind this? When you place a internal bevel incision, it removes the entire pocket lining. Okay, right? If you go, when we remember this ENAP, okay, when we discussed about ENAP, right? So in ENAP or excision new attachment procedure, there also we gave a internal bevel incision, right? So aiming at the crest of your alveolar bone. So here also, right, the internal bevel basically starts from some distance from your marginal gingiva, aiming at your alveolar crest, right? So when you see this diagram, the blade is held parallel to the long axis of the tooth. When you see the diagrammatic picture here, it is right at some distance, that is, it could be 0.5 to almost as 2 millimeter. Okay, 0.5 to 1 millimeter goes with your modified Widman. If it is going to be 1 to 2 mm, that is going to be your original Widman flap. Now this is almost parallel to the long axis of the tooth, and it is aiming at your alveolar crest. Now, what this does basically is it removes this entire pocket lining, right? That is the first objective. The second one is it also thins the flap. Okay, right? So it also thins the flap. Okay, now when you see here, there's a beautiful internal bevel incision all around, right? Going across the teeth. Okay, so this is your internal bevel incision, the first incision, right? It's also called as the reverse bevel. It's also called as the inverse bevel. Objective, as I said, it removes the pocket lining, right? It removes the pocket lining and also thins the flap. The second incision is called the crevicular incision, or what we call the sulcular incision. Okay, right? So the second incision, crevicular, sulcular, right, or the second incision. Okay, now it is made along the crevice, right? The first incision was here, right? The second one is you're going to put the blade here, and then you're going to give the incision, right? Now the first incision is this, right? Right, some distance from your marginal gingiva. The second one is going to be you're going to put the blade inside the crevice and then move it in a mesiodistal direction, right? So again, this becomes a horizontal incision, right? Now, along with the first incision, that means along with this, if you place a second incision, you are going to get a V-shaped wedge of tissue. Now, this contains the pocket lining. So, right, so this has to be removed so that the entire pathological tissues which is present here will be removed. So again, I repeat, along with the first incision, when you give this second incision, it creates this V-shaped wedge of tissue, right? Are you getting it here? This is one part of the V, and this is one part of the V. So you get a V-shaped wedge of tissue, and this basically contains the pocket lining. Okay, right? The third incision is horizontal. Okay, now third incision, basically when you go back here, third incision, that means once you give the first incision, you're going to reflect this flap. I'll show you this a little bit later. The second, you're going to give a crevicular incision. The third one is right, aiming here directly. This is called the horizontal or interdental incisions. Okay, interdental incision also comes under your horizontal type of incisions. Okay. Next, we come to the vertical incision. Now, this is incision basically, again, I told you when is given when the flap is to be displaced, whether you want to displace the flap coronally or if you want to displace the flap apically, right? So here, as I said, you're going to give horizontal incisions in a mesiodistal direction, and then at the end of the mesiodistal incisions, you're going to give one here and one here, right? Now, remember, these vertical incisions must always extend beyond the mucogingival junction, right? Then only you will be able to displace it either coronally or apically, right? Are we getting it here? Right. So we have placed the incisions, vertical incisions here. One vertical incisions here. This was a mesiodistal extension. Now this incision basically crosses your mucogingival junction. Right now this can be placed either apically or it can be placed coronally. Always remember that whenever you're giving these vertical incisions, there are certain techniques. Okay, there are proper method. Okay, you are not going to split the papilla. Now this is your papilla. You are not going to make incision directly right across the midline. Neither you're going to give incisions right at the mid buccal area of your root. Okay, so you're going to incorporate one of the papilla into either this side or this side, right? So when you see here, I mean, there is an incision placed here vertical. So this papilla is preserved. When you give incisions here, this papilla is preserved. So it should be at the line angles of your tooth. Okay, so just remember this much. Okay, right. Next, we have something called as a thinning incision. Okay, it is also called as undermining incision, or it is also called as an internal incision. Basically, these are used beneath your flap, that is at the inner aspect of your flap to debulk. Okay, if you want to, there is a thick flap and you don't want a thick flap, so we try to remove most of the connective tissue, right? So this is called as the thinning incision. That means basically you're going to thin the flap. So where are those indicated? These are indicated in the palatal flaps and the distal wedge flaps. Okay, as you know, palatal flap basically is sometimes are quite thick. So we don't want a thick flap. Thick flap again can get reinfected if not maintained. So we need to thin the flap. The next one is something called as a periosteal releasing incisions. Now these incisions are placed at the base of your flap. That means once you have given two vertical incisions, you have reflected a flap and the flap has gone beyond the mucogingival junction, and now you want to coronally advance the flap, right? Right, you want to coronally advance. So one of the key indications of your complete root coverage is there should not be any tension of the flap. So you want a flap which is placed without any tension. So for that, basically, we give incisions at the base of your flap. That is called as a periosteal releasing incision. So where you want to release the tension on the flap to advance this flap either coronally or laterally, right, or apically. And these are basically used along with your bone grafts or with your collagen membranes. Okay, that is either with GTR protocol or with your guided bone regeneration procedures. Okay, GBR procedures. So let's come to the main technique, the main aspect, that is the techniques or procedures for accessibility as well as either for the pocket depth reduction or for pocket elimination. So there are different periodontal flap surgical procedures which has got its own objectives. The first one we'll be talking about will be original Widman flap. Then we'll be talking about the modified Widman flap, a little bit on the Kirkland flap, apically displaced flap, and then finally we finish with a papilla preservation flap. Okay, so let's see. I'll be just describing with the clinical photos or with a diagrammatic photo so that you will be able to understand it much better. So let us see the first one, that is your original Widman flap. The original Widman flap was devised by Leonard Widman way back in 1918. Okay, 1918. So it is a full thickness mucoperiosteal flap which was aimed at removing the pocket lining as well as infected connective tissue. Okay, right? And this completely eliminated the pocket. One of the key takeaway of this surgical procedure is it doesn't reduces the pocket depth, but it eliminates totally the pockets. So let us see the procedure. Okay, the first procedure is obviously before any periodontal surgical procedure, you are going to give some sort of local anesthesia, just like your gingivectomy procedures, right? So you are going to give a local infiltration or your regional block, okay, depending on the extent of your surgical procedure, okay, of the extent of the surgery. Okay, the first thing what you're going to do in original Whitman flap is you're going to give two vertical releasing incisions. Okay, right now this is your area of interest, so you're going to give two vertical incisions extending well beyond your mucogingival junction. Okay, the second one what you're going to do is you're going to give the first incision. So what is the first incision? It is an internal bevel incision, or what we call the inverse bevel incision or the reverse bevel incision, right? So here in original Whitman flap, the incision basically starts 2 millimeter, 1 to 2 millimeter away from your marginal gingiva, right? When you see here, incision is placed here, right? That is 1 to 2 millimeter away from the gingival margin. A internal bevel incision is placed aiming at the crest of your bone, right? So that is the first incision is given. Once the first incision is given, right, you see here, this flap is raised. Understand, right? So the first one is you're going to give two vertical releasing incisions extending well beyond the mucogingival junction. The second step you're going to give is the first incision, which is also called as an internal bevel incision or an inverse bevel incision or a reversible incision, starting 1 to 2 millimeter away from the gingival margin, aiming at your alveolar crest. Then you're going to reflect this full thickness flap with the help of a periosteal elevator, right? And then you're going to go with your second incision. What is the second incision? The clavicular incision or the sulcular incision, right? So your first incision, that is internal bevel incision. The second incision, that is your sulcular incision, right? Now this will, as I said, will give you that V-shaped wedge of tissue which contains the pocket lining, right? Now this tissue is basically removed with the help of your curettes. Okay, now this is removed with the help of a curette. Then what you do is you go into the root surface, you're going to do a complete root debridement, thorough root debridement, right? Making sure that the root surface is smooth, hard in consistency, right? Next, what you're going to do is whenever there is an irregular bony contours, you're going to do osteoplastic procedure. Also, you're going to take a round ball and make sure that the original contours of the bone is restored, right? So here in original Whitman flap, you're going to do osteoplastic procedure also. Either you're going to do a reduction, right, using burrs. Okay, and then what you do is very important. You're going to irrigate this area nicely, making sure that there is no granulation tissue or there is no root irritants left back. You're going to inspect thoroughly, and then you're going to place this flap margins apical to its original position. That means you're going to place this flap on the root surface. So the root surface is here, when you see here. So you're going to put back this flap right at the level of your bone. The bone is present here, right? So you're going to put back this flap at a more apical position, right? So the first one is you're going to give two vertical incisions. Then you start with your first incision, that is called the internal bevel incision, right? You're going to reflect a full thickness mucoperiosteal flap. Then you're going to go with your clavicular incision, right? Now this forms a V-shaped wedge of tissue which is going to be removed by your curettes, and then you're going to go with a thorough root debridement along with the osseous reduction using burrs. making sure it is nicely contoured, and then finally you're going to put back this flap at the position of your existing bone. So bone level is here. One of the technique is what was advised by Leonard Whitman is he never covered this interdental area. So it was also called as an interdental denudation technique, right? He had this, he had hypothesis that if you don't cover the bone and the interproximal area, the tissue heals by a secondary intention. So there is no formation of a pocket there. Okay, right? So this is your original Whitman flap. Okay, now let's see the modified Whitman flap. Okay, it's just a modification, a slight modification given by Ramford and Missel in the year 1974. Now, one of the main objective of this modified Whitman flap was this flap exposed the root surface for meticulous instrumentation of the root surface as well as removal of your pocket lining. So here the objective was not to eliminate the pocket, but rather by doing this two procedure, that is removing the root surface accrements as well as removing the pocket lining, it led to a reduction in the pocket depth. Okay, so let us see what are the steps. So incisions used in modified Whitman is just like your incision used in the original Whitman, right? So the three incisions, the first incision is called the internal bevel incision. The second incision is called the sulcular incision. The third one is called the horizontal incision. Okay, right? So the difference here between original Whitman flap and a modified Whitman flap, I'll be showing a little bit later once I conclude this surgical procedure. So after you give an adequate anesthesia, you place the first incision. Here you are not going to place vertical incisions. Okay. Now, original Whitman, the first thing we did was we placed a vertical releasing incision. But here in a modified Whitman flap, you are not going to place any vertical incisions. So the first incision you're going to place is a inverse bevel incision or a reverse bevel incision or a internal bevel incision. So either you can use a 12B blade or you can use a 15 number blade. Now, in a original Whitman flap, the distance from the gingival margin was basically 1 to 2 millimeter, right? So here we are going to be more conservative. So we are going to be only placing 0.5 to 1 millimeter, right, from the gingival margin, and it is aimed at the alveolar crest. Okay, right? In aesthetic zones, especially in the anterior, we are not going to use this 0.5 to 1 millimeter. Also, we are going to we will be placing a clavicular incision instead of an internal bevel incision, especially in the maxillary or mandibular anteriors, because we don't want any recession to take place, thereby creating an anesthetic appearance, right? Okay. So as I said, the first objective of this first incision is it separates the pocket wall from the rest of your mucoperiosteal flap, and also it produces a healthy thin margins. Okay, right? So that is the objective. It removes the pocket lining. It produces a V-shaped, sharp, thin flap margins for a proper flap adaptation. Okay. So when you see this diagram, right? So here this is the original work done by Whitman. So here also they have placed this internal bevel at 0.5 to 1 millimeter away from the gingival margin. So this is your gingival margin. So you're going to place your first incision, internal bevel incision, right, about 0.5 to 1 millimeters, right. So this is your gingival margin. So you're placing the incision parallel to the long axis of the tooth, aiming at your alveolar crest. So you can use a 12B or a 15 number scalpel blade. So once you do that, what you're going to do is you're going to take a periosteal elevator, and then you're going to reflect a full thickness mucoperiosteal flap. Okay. Once you give the internal bevel incision, you're going to reflect a mucoperiosteal flap. Okay, for visualization of your root surface. So when I say that, I mean this is okay. So you have placed the first incision here. Now we are going to use a periosteal elevator, and you're going to reflect a full thickness mucoperiosteal flap, right? So this is your pocket lining, which will be removed by using the third incision, that is your interdental incision. Okay. Now, second incision, as I said, is also called as a clavicular incision or a sulcular incision. Okay. Now, this incision is carried out. Excuse me. This incision is carried out all around the tooth. Okay. Right. The purpose is to facilitate removal of the granulation tissue or the pocket lining surrounding the cervical area. Okay. Now, as I said in the previous slides, that it produces the first incision and your second incision produces a V-shaped wedge of tissue. Basically, this contains the pocket lining, right? So this is the clavicular incision. So you see here a 12 number blade is inserted into the crevice and it is moved all along the tooth surface. Okay, right? So this is how the blade is oriented here, right? So this is your first incision, this is your second incision. Now this creates a V-shaped wedge of tissue which contains the pocket lining along with the granulation tissue as well. The third one is called as the interdental incision, right? Right. The third one is called as the interdental incision. Now, basically, this is used with a Orban's knife. Okay, right? Now, once you use this Orban's knife, it removes the collar. Okay, it removes the collar from the root surface or from the alveolar bone. So, when you see here, right now, this is your collar. Okay, the first incision was given here. The second incision was here. So the third incision basically is this. Okay, now this removes this collar. What we know, this is called the collar of infected or the pathologic tissues. Okay, right now this is how this it is going to be. Right now this is called as the interdental incision, basically given with a Orban's gingivectomy knife. Right now, once you do that, what you see here basically is access to your root surface. Okay, so you're having an access to the root surface, so you can go and with your doing your root planing, all right, because you have a direct access to the root surface. Okay, right. So you're going to do a complete root debridement, you're going to irrigate it, and then you're going to suture it. Okay, right. Again, you're going to place this flap right at a more apical position. So here again you have the root surface which has been exposed, basically, which is more of an anesthetic in appearance. So again, this the anterior area where there's deep pockets, right? So the first thing is you're going to give an internal bevel incision starting from 0.5 to 1 millimeter from the gingival margin. You're going to place your clavicular incision, right? This is your gingival margin. You're going to aim start from here 0.5 to 1 millimeter, aiming at your crest of your alveolar bone. Now this is your pathological pocket lining, right? The second one is next is you're going to reflect. Now this is incision is completely done all along this tooth surfaces. So along it is carried along the palatal aspect as well. Okay. The next one is you're going to elevate a mucoperiosteal flap, and then you're going to use your second incision, that is your clavicular incision. Okay, right? And then you're going to remove this collar of tissue by using a Orban's interdental gingivectomy knife, right? And then you're going to do a thorough root debridement. Okay, you're going to irrigate it, right? And then you're going to place the sutures. Okay, right? Now this is how the tissues will look post-operatively. There is a formation of this dark triangles, okay, or what we call black spots. Okay, right? So we'll end up with this slide. The differences between original Whitman and modified Whitman flap. Okay, original Whitman flap was aimed at the pocket elimination, whereas in modified Whitman flap, the objective is pocket reduction. The first incision starts 1 to 2 millimeter from the gingival margin in the original Whitman flap, whereas it is just 0.5 to 1 millimeter from the gingival margin in a modified Whitman flap. We use vertical incisions in a original Whitman flap, whereas there are no vertical incisions used in a modified Whitman flap. Bone contouring is done in a original Whitman flap, whereas no bone contouring is done in a modified Whitman flap. The flap is placed at an apical position right after your surgical procedure in an original Whitman flap. In a modified Whitman flap, you are not going to apically displace the flap. You're going to put back the flap at the same area. Okay, right? So we'll end the topic at here, and then we'll continue with the next surgical procedures in the next lecture. Okay, so if you have any doubts, please go through the text once again, right? And you're always welcome to come back with doubts, if any. Okay, right? So till we see you again, I have